All right. Any questions from last time? Was it yesterday? I think it was yesterday. Life is all a blur at this point. So I had a good question that came up yesterday. Someone's like, well, if you have like a lady who's getting close towards menopause, but she's on oral contraceptives, which we said typically, like birth control type medications, usually a lot higher estrogen sort of doses than you would see with like typical hormone replacement, right? Because again, with OCPs, we're trying to like basically shut down the whole system essentially. They said, well, as they're getting closer to menopause, like, how do you know when they don't really need it anymore? How would you switch them off? And so I was like, I don't know. That's a good question for like a gynecologist or someone who deals with that pretty routinely. And so Professor Lack talked to one of her friends who works in gynecology, and so she actually had an answer. So for any of you that are curious, they said basically as a woman gets closer to that age where they would be expected to develop menopause, a lot of those symptoms that they would develop anyway due to their ovaries not producing enough estrogens, they would actually, it's being covered up basically with the OCPs, right? Because again, we're supplying that estrogen and progestin. And so what they would say is that what they would actually do is they'd leave them on the OCP until they get to the placebo section of the pack, that week 4, and then they would go ahead and check their FH levels at that point. And presumably, if their ovaries are not producing a lot of estrogen, should their FH levels be high or low? Should be high, right? Because again, they're not producing estrogen to feed back on that feedback loop. And so they see they're really high, then they would say, okay, well, it is likely that you are in menopause. And so they would then, either probably most likely titrate them off of the OCP and then switch them over to like typical hormone replacement therapy sort of doses at that point. So that was one way to do it. I don't know if they would do it differently elsewhere, but if you're curious, that was something that may be done. So anyway, okay, so everyone turn your frown upside down. We get to talk about behavioral meds now. You just got done with CBM, right? So we get to do even more fun stuff. Let's talk about what you all have developed after taking physio, and then got a little bit worse with intro to pharm, and then really got worse with epi bio and pharm at the same time. It's major depressive disorder. That's okay. Okay, so anywho, so depression and anxiety, sure, as you guys know, that a lot of these two go hand in hand in a lot of cases, and so it's really important that we are kind of addressing both. And so we'll see that with our pharmacotherapy here. We've had meds to use against these since the 1950s, but they've been pretty toxic for the most part. You guys know any of those like examples like pretty toxic meds that we used to have that we still? They talked about them briefly with Professor Austin. MAOIs are going to be some of them. TCAs are going to be the other big ones, and so we'll talk about those briefly. TCAs you'll still see used pretty regularly. MAOIs are kind of going the way of the dinosaur for the most part. You'll see them occasionally, but not too often. However, when do we talk about using an MAOB inhibitor? For Parkinson's, right? Yes, we've already talked about one use you can see for monoamine oxidase inhibitor. The ones we're using for depression were non-selective, and so that'll be important when you're looking at drug-food interactions and whatnot, which we'll see here in a minute. So anyway, oftentimes it's kind of difficult to determine what's going to be the most effective therapy. One of the problems with a lot of these trials and things like that is the placebo effect. So again, oftentimes if people have depression, anxiety, if they feel like they're doing something for themselves, they're taking the pill, even if it's a sugar pill, that that kind of psychosomatic effect of the placebo can be pretty important, and that can actually have some kind of alleviation of some of their symptoms, in fact. And so that's one of the problems with a lot of these therapies is that we don't have sometimes the studies are not super well defined as far as their outcomes go, and it's hard to do head-to-head trials. And so this is one of those things where you're going to see that patient or which medications you're going to prescribe are going to be very much dependent on the patient, and not going to be necessarily you start with sertraline. If that doesn't work, then you go duloxetine. It doesn't really go quite that easily. You're going to find there's a lot of switching within a class. Some people may respond really well to sertraline, but then not respond so well to fluoxetine, and you'll see some interpatient variability there. So that's one of the difficult things is it's kind of a shot in the dark, but we'll talk about some general guidelines to go with as we go over these meds. So certainly there's other reasons for a patient to have symptoms of depression and anxiety. A lot of conditions that go along kind of older age, so especially like Parkinson's, hypothyroidism is another big thing. You want to rule a lot of these out prior to prescribing for depression and anxiety, and try to deal with it as best you can. Certainly there's plenty of medications that can influence this, so things like isotretinoin can have effects on mood, anticonvulsants as we mentioned, so things like Keppra having kind of that increased aggression in children kind of being the unique thing there, but you can still see some alterations in mood. Some cardiovascular agents like beta blockers, hormonal therapy, so lots of different things can affect this, and so you want to fix those underlying issues, which is why it's so important that you get a good medication history out of these patients beforehand to see if there's anything kind of underlying line there that you can perhaps alter or change to avoid having to add on another medication, because you don't want to get in that sick cycle where they have side effects from a medication, then you treat it with a different medication, and then they get new side effects, you have to treat it with a different medication. You don't want to have to do that, right? Okay, and then obviously the big thing we want to make sure is that we are catching these patients. You know, I think there's a lot of stigma against mental health that is starting to go a little bit by the wayside. Fortunately, we're starting to discover more of these people. They're getting more treatment, because obviously the big thing we want to prevent is from them suicide, self-harm, right? And so that's where I saw a lot of these patients, is when unfortunately they fail their therapy and they decide to take it all at once, and they come and see me at the poison center, or call us, or we deal with them in the ER or something like that. So I'll have a few anecdotes to kind of go along with that from a kind of a talk standpoint. So obviously anxiety has several different conditions. I was actually diagnosed with obsessive compulsive disorder at one point in my life. It was so bad I had to classify it as CDO. So, and it just, anyway. I already said that one? Oh, you've heard it before. Okay, that's fine. Well, whatever. Well, all of you guys are probably going to have PTSD after you get out of here, so there you go. So we're all going to have anxiety, all right? Anywho. Anyway, so again, we are looking to make sure that we're prescribing therapy for dealing with anxiety if they're having symptoms that are kind of interfering with their normal function. A little bit of anxiety in life is okay, especially like before a test or something, but if it goes on and starts to interfere with normal life processes, that's where you want to intervene here. And again, very much often associated with depression. These go hand in hand. Oftentimes, anxiety worsens depression, and depression can worsen your anxiety. So again, we have to interrupt the cycle as best we can with our meds. So, why do people get depressed? What is the pathophysiology there? So traumatic events. What's the neurochemical basis for this, though? Decreased serotonin? That's what we think, right? It's what we thought for a little while, but we probably don't actually know the full reasoning behind that. And we thought that for a while because there's actually one reason. There's a drug called reserpine that actually depletes a lot of brain catecholamines like your dopamine, norepinephrine, serotonin. And they saw that a lot of patients who were taking this actually became depressed. So it's okay, it must be due to lack of serotonin. So we're going to give you medications that increase levels of serotonin and norepinephrine. That seemed to help. However, even though that the mechanisms, directly will affect levels of serotonin, that's not really the full story, because how long do these drugs take to work? Take 4 to 6 weeks before they really kick in and really have full efficacy. So that doesn't really make sense, because they work immediately to increase those levels of serotonin. So you would think that it would fix your depression immediately. Not the case. So we know there's probably some downstream effects. We don't know the full story. However, there's plenty of theories that are out there. But our main purpose is that when you look at the medications, knowing their mechanism is going to more clearly define what their adverse effects are going to be. And so it's important to keep that in mind when we're looking at these different classes here, right? Okay. So our main goals here, we want to reduce the symptoms of acute depression, right? Try to deal with any kind of acute issues there, try to get them back to a normal level of functioning, and then obviously prevent further episodes of depression if possible. So the 3 phases of treatment mainly, you have kind of the acute phase, which is kind of early on, where we'd hopefully get into remission of symptoms. They're having kind of an acute episode. There'll be this kind of more continual phase where you're starting to see, okay, how are the medications working for the patient? How can we kind of optimize therapy for them? And again, hopefully to prevent recurrence of their acute symptoms, hopefully. And then again, there'll be more kind of maintenance phase. They're kind of just trucking along, and everything should be going well for them, hopefully. And again, hopefully preventing recurrence there. Now, are people going to require lifelong therapy? Sometimes, yeah. Sometimes it's more situational. It's kind of a short-term sort of thing, so like a death in the family or some other event that's causing kind of a more short-term kind of acute depression. But in a lot of cases, you may find patients need lifetime therapy, right? It's just the way their brains are wired. That's okay, but they may require this for the duration of their life. That's okay. But you'll find this is going to be more needed for patients who have shown to have recurrent episodes, to say 2 or more episodes. Probably is going to require some degree of really long-term sort of therapy there. And again, adherence and patient education are super critical, because as I mentioned, the drugs take a while to work, to really kick in, but when do the side effects happen? Right away, right? So if I'm depressed and I'm feeling really really bad, but then I'm getting this medication, like, all right, this is going to fix everything, but I feel worse before I start to feel better, I'm probably not going to want to stick with that regimen, right? And so compliance is a big thing. It's important to educate on side effects, make sure we are addressing those issues and those concerns, and maybe switching over to a different medication where applicable. And so we'll talk about that, what makes one drug maybe better for one patient versus another, because that's going to help us to increase compliance, and that's going to help us out overall. Hopefully get the best kind of results out of these patients. Because again, if they're not taking them, and a lot of times, can you trust the patient when they say, yes, I'm taking all my medication? Not necessarily, right? And so they may tell you what you want to hear, but it's not really doing anyone any benefit. So again, compliance is always going to be a big concern here. So obviously psychotherapy can be very useful and actually find good synergistic activity or between antidepressants plus using some kind of psychotherapy. So I definitely recommend people getting both. But people tried other things like electroconvulsive therapy. You know, shocking, I know that people still undergo that. Anyway, there's the on this Friday afternoon. I'm trying to pepper those in. Anywho, has anyone heard of this transcranial magnetic stimulation? It's kind of an interesting thing. So I didn't know much about it. I actually had a friend who's a paramedic. They got a job working as a tech doing this for a period of time. And basically it was this kind of machine that they were hooked up to. It was kind of this like wellness kind of clinic, more like holistic kind of medicine. And they basically had these like kind of probes that would sit right on the forehead that would kind of beam in these like magnetic waves, I guess. I don't know a ton about it, but apparently there's some studies that actually back up say that it does have some efficacy in treating different anxiety disorders, schizophrenia, things like that. So there's lots of things that are out there from a non-pharmacologic standpoint and certainly are worth looking into as long as there's decent evidence to back up some use there. Anyway, though, we want to focus on drugs because we like drugs here, right? So as I mentioned, 30 to 40% of people are going to respond just to placebo alone. So it's hard to pick what to decide who's really going to benefit from which medication best. Typically, you're going to make this choice made based on empiric things. Parts of the history of the patient, looking at their history of response, maybe to other medications, had they been previously treated before, looking at things like, concurrent medical illnesses. So, can some of these drugs exacerbate certain medical illnesses? Sure. We're going to look at that and help us to guide which medication might be better for our patients. Cost is a big thing. Obviously, if the drug is expensive and the patient can't pay for it, they're not going to take it, right? So insurance coverage may be important here. Drug-drug interactions are going to be a big deal, which we'll address here. And then looking at their adverse reaction profile. So again, a lot of patients will not discontinue use of a drug because they're not working, it's not effective for their depression. It's going to be because of side effects more often than not. So you got to watch out for that. And obviously patient preference is going to be a big deal. So how do we classify antidepressants? We kind of alluded to this already. Some of them are based on chemical structure. Which ones are they? Just based off the name, it's a structure. Tricyclic, right? So tricyclic antidepressants are based off the shape of the molecule, right? So if you look it up, they're 3 cyclic rings to them. The other ones are going to be based off their mechanism. So monoamine oxidase inhibitors, again, the mechanism's right there in the name. SSRIs stands for selective serotonin reuptake inhibitors. SNRIs are yes, those are serotonin norepinephrine reuptake inhibitors. I guess you could call them like SSNRIs or SNRIs, whichever. The nomenclature doesn't really matter there. But again, that'll inform you what the mechanism is, and that informs you what a lot of the side effects are going to be regarding those. Tricyclics are just kind of an old school set of drugs, and they just kind of, for whatever reason, got that nomenclature. But again, knowing the mechanism is going to help you inform the side effects and the efficacy. So, as I mentioned, it takes 2 to 6 weeks before you really start to see the efficacy of a drug really start to kick in, but I mentioned the adverse effects are going to happen much more immediately. And so the failure rate can be pretty high with these. So anywhere between 20 to 30% of patients may fail on the initial antidepressants you prescribe for them. Some of this may be due just to intrinsic kind of resistance to it, due to pharmacogenetic differences. They may respond better to one SSRI versus another. So again, it's hard to predict who that's going to be. We don't have good tests for that necessarily. Could be due to inadequate drug dosage. Maybe they weren't getting a big enough dose, or maybe they didn't try it for long enough. They kind of quit, say, a week in because the side effects were intolerable. And then non-compliance obviously is a big deal. So either getting a delay in therapy, or maybe they're, they have a issue getting access to the medication for whatever reason, or due to adverse effects, whatever. But non-compliance will be another big issue here. So, and even just on placebo alone, people will have natural remission of some of their acute kind of depressive symptoms, within 6 to 12 months. Some people just respond on their own. That's okay. But a lot of them will develop recurrence. So this is where a lot of our medications are focused, is to try to prevent that recurrence, which is why we're treating this as kind of a chronic disease here. And what you'll see is that, between the TCAs, the SSRIs, SNRIs, the efficacy does not differ greatly between them. A lot of it goes back to the side effects. And again, some people respond better to TCAs, some people respond better to SSRIs. There's no way to really note that. However, the adverse effects are going to be much, much different. So which ones are much more dangerous, do you think, between the TCAs and SSRIs? TCAs are, by and large, way more dangerous than the SSRIs are. And one of the things you'll note, and we'll talk about this a little bit later, is that, usually like when a person's depressed, like how's their energy levels doing? pretty low. They don't want to get out of bed. They don't want to do anything. They don't even enjoy the stuff they used to enjoy anymore. They may have thoughts of self-harm, right? But the problem is they don't really have any energy to act on those thoughts, right? So that's usually what that can be a reason why they do not act on these thoughts. However, one of the things you'll realize when you start a patient up on an SSRI or any of these antidepressants is all of a sudden they get a little more energy all of a sudden. So they get a little more energy. We'll talk about this term called akathisia a little bit later on. And now they have just enough energy. They're still depressed, but now they can act on these thoughts of self-harm, right? So this is when they, and you'll find that a black box warning for a lot of these drugs is what? Suicidality, which doesn't make sense. Like, why are we giving drugs to people who are potentially suicidal to, that cause suicidality? Well, the reason for that is that little kind of energy boost they kind of get early on, I call it. And so if you take a 10-fold overdose of a TCA, potentially life-threatening. If you take a 10-fold overdose of an SSRI, not too bad. You can take like a 20-fold overdose, probably not so bad. You'll have some effects, but it won't be nearly as bad as a TCA. So that's the reason why we use these newer drugs that are much more specific, and we'll talk about why TCAs are much more dangerous than SSRIs in a little bit, but just know that it has to do with specificity of their mechanism and being much more specific for just one target rather than affecting lots of different systems in the body. Okay. So looking at the older to newer agents here, we have the monoamine oxidase inhibitors, which are kind of our first agents that came about from these. And you'll notice that there's a lot of chemical similarity between a lot of the kind of earlier antipsychotic drugs and a lot of these early antidepressant drugs. There's a lot of crossover between them structurally, which is why you see a lot of side effects that kind of bleed over. We'll talk about antipsychotics probably next week when we get to them. But anyway, monoamine oxidase inhibitors, they're going to be working to prevent breakdown of serotonin and norepinephrine. That's their main mechanism of action. What you'll see is, remember when we talked about like selegiline for Parkinson's, you remember which enzyme specifically that worked on? It's like monoamine oxidase B, remember? So again, there's an A and a B isoenzyme here. These are going to be non-selective, so they'll work on A and B. So you're going to see that they're going to have a little bit wider array of activity. They're going to have more side effects associated with that because they're not selective. And also you're going to find these are also irreversible, which we'll talk about in a second. Then you have the tricyclic antidepressants. Their primary means of treatment for depression are going to be this blocking of reuptake of serotonin and norepinephrine, so they'll directly increase levels of both of those catecholamines, or both of those monoamines within the synapse. So that's their supposed mechanisms of action. Well, the SSRIs, which are specifically just affecting serotonin, and then we'll have our newer agents. We'll have a few that are miscellaneous that aren't kind of listed here, but we'll have a few SNRIs as well that are working on norepinephrine and serotonin. What do you think of the difference between the SNRIs and the TCAs as far as mechanism? You guys talk about that at all? Good, yeah, TCAs are anticholinergic. That's a big reason why they have a lot of side effects associated with them. The SNRs do not do that. They specifically just work on blocking reuptake of serotonin and norepinephrine, versus the TCAs are going to have a lot more receptors they're hitting on. We'll talk about the anticholinergics and some other receptors they hit as well here in just a second. So this is a fun picture. So imagine here we have our synapse. We have a norepinephrine or noradrenergic neuron here. We're going to have our serotonergic neuron right here, right? So 5-HT for serotonin and E for norepinephrine. And so typically you're going to find that the norepinephrine will be stored in a vesicle. It will converge here with the membrane. It'll be released out to the synapse, but they can then react on whatever receptors are going to be acting on, right? Norepinephrine acting on things like alpha receptors and beta receptors and whatnot. And then they'll have a transporter here where they get recycled, basically. So they'll get recycled up. Monoamine oxidase may interact with it at that point, where they may metabolize it. Otherwise, it's going to be repackaged into a vesicle, which can then be sent out again, right? We have to be efficient and recycle these neurotransmitters whenever we can. Same thing happens with serotonin. Serotonin being released out of the vesicle, and then they should go through the serotonin transporter here. Now, looking at how these different drugs are going to be working, you're going to see obviously the monoamine oxidase inhibitors are working on MAO very specifically to inhibit breakdown. So it's going to be important when we're looking at drug interactions in just a little bit. But then you're going to have the TCAs and SNRIs are going to be working here on this norepinephrine reuptake transporter. SSRIs, TCAs, and SNRIs again working on the serotonin transporter. So note here, SSRIs are only working on this serotonin transporter, really no norepinephrine effects, which will be important for side effects. The other thing to note here is that TCAs are working on this alpha-1 receptor. So this is going to be another big side effect that we run into with TCAs, is they block alpha-1 receptors, and that can lead to what effect might you expect? Alpha-1 is really important for what sort of vasoconstriction, right? So if I block alpha-1 receptors, what could that cause? Vasodilation leading to Hypotension, yeah. So hypotension is going to be a big thing. We're going to see that. That's another reason why the TCAs are so dangerous, which we'll talk about here in just a minute. So anyway, again, we don't know what the downstream processes that are happening here that are eventually, the kind of downstream effects that are causing an alleviation of our depressive symptoms. But at a baseline, this is what mechanistically the drugs are actually doing themselves. So again, use this as a reference and kind of go back to and see how these drugs are working here. Okay. So again, in general, these should be enhancing, all these drugs are enhancing the effects of either norepinephrine, serotonin, or just serotonin by itself. And again, the full mechanism is not really known. So there's lots of different theories on what we're seeing here, either changes secondary messenger systems, different transcription products, who knows. Our main purposes here, we're just focusing on are what the actual mechanisms are for each of the individual classes so that we can inform what the side effects are. Because again, therapeutically, they're working almost the same, all take about the same amount of time to really kick in and work. All are going to have equal efficacy, relatively speaking. So starting off with the MAOIs, we're going to have, again, this is the oldest group. This is going to be the most kind of drug interaction prone, most kind of side effect prone, kind of tied with the TCAs from the side effect profile. But epronizid was one of the first ones. It was actually an anti-tuberculosis agent. And what they noticed was you'd have these patients, they were in these sanitariums or they were basically kind of quarantined off from everyone else. And they noticed that these TB patients, they actually had kind of elevated mood while they were receiving this. And they're like, that's kind of interesting. So I said, okay, well, maybe we can try to give this to other patients. And they realized, hey, other patients get their moods elevated too. So it's kind of one of our first drugs we kind of realized, hey, maybe it could have effect here for depression. And that led to eventual development of things like phenelzine, isocarboxazid, and tranylcypromine. Big thing to note here, these are irreversible inhibitors of MAOA and B. What do you think that means as far as duration of action goes if they're irreversible? A lot longer, right? So you have to regenerate the enzyme. You have to make a whole new enzyme in order for the effect to kind of go away. So that means that even if I discontinue therapy today, how long do you think that effect will stick around for? As long as it takes to replenish those enzymes, right? So it could take up to like 2 weeks or so before you really start to see those effects go away, which is why they can be pretty dangerous. Because even though I stop taking the medication, I can still have a drug interaction down the road because those drugs are still around, right? So it's one of the things to consider there. Also consider that they're blocking the metabolism of not only serotonin, norepinephrine, but also dopamine. And this can have a big interaction if you were to have excess supply of precursors to these monoamines, namely tyramine. Where did we talk about tyramine before? Yeah, so some of the foods that contain them are things like aged cheeses. What else? Red wine. Some dark chocolates, fava beans, cured smoked meats. Some you get yogurts and things like that. It's really a lot of the good foods in life higher in tyramine. And again, if you're blocking the metabolism of these monoamines and you're increasing the supply of precursors, you're going to get way too much of that product there, and that's where you can see a lot of the toxicity. And what's one of the big toxicities we worry about with having too much serotonin? Serotonin syndrome, right? So again, we name these things to try to be convenient so they're easier to remember. But we'll come up again and talk about serotonin syndrome in just a little bit here. So the two big ones we see used for depression include phenelzine and tranylcypromine. Again, we already talked about selegiline before as being an example used for Parkinson's. So I just kind of list this here just to kind of jog your memory and think back to your neuro section. Now, one of the big things you're going to see is by affecting, norepinephrine homeostasis, you're going to find that postural hypotension can be one of the most common side effects you're going to run into, and this could be bad in some of your older patients because what can happen? Yeah, falls are going to be a big deal. They stand up, they get dizzy, fall over, have a hip fracture. It's not going to be good. In fact, if I broke my hip, I'd probably be much more depressed than I was before, right? So again, not something you want to do. You can see weight gain with some of these medications, specifically the MAOIs as well. And then sexual side effects. You're going to find sexual side effects are going to be with a lot of these antidepressants. And again, it could be another thing where it's like, okay, well, I'm treating my depression, but now I don't want to have sex anymore, straining my relationship. Again, that can worsen, some components of their mental health. So again, we'll look at someone specific one agent that is actually going to be very low in sexual side effects and may be a good option if your patient's having any of these issues here. So just keep that in the back of your head. The other big thing you worry about is having this kind of hypertensive urgency that can happen here. This is going to be seen when typically you're mixing medications. They're going to be increasing the effects of serotonin or epinephrine. These are going to be if you're having increased tyramine intake. These are going to be if you're having stimulants and things like that. So we'll go over some of those lists that can do that. But keep in mind, if you have multiple drugs that are stimulating that kind of catecholamine pathway, these can lead to this very significant rise in blood pressure. You can see MI in patients, cardiovascular disease. You can see CVAs develop here, lots of big issues. You have to be really careful with this. And this is, again, why we don't use these drugs very often anymore. And again, even if you stop the drug after discontinuation, you have about 2 weeks before those enzymes regenerate. So it's going to take a while before that really to wash out for them. And again, this would be treated with antihypertensives. So So going back and thinking about like your nitroprussides, your nitroglycerins, labetalol, things like that is kind of good IV agents would be necessary to get the blood pressure down for these patients. It can be pretty severe. So just again, some of the foods here. So again, you can't have your nice aged cheeses and no wine. So it kind of gets rid of some of like your French foods, and no MSG. So kind of some Asian foods are kicked out of here. Don't go to Germany because you can't have any sauerkraut. So all the good stuff in life is basically gone. So yeah, no good. Even coffee has some tyramine. Who knew, right? So again, lots of stuff there you have to watch out for. And again, just a big reason why we just avoid these drugs altogether. The big thing to note, though, is that not only these monoamine oxidase inhibitors themselves do this, but we're going to find some kind of some secret monoamine oxidase inhibitors, some we've already mentioned before, that are contained in drugs that you wouldn't even think about. So kind of keep that in mind. There'll be some interactions I'll talk about later on. So other things that can interact with these monoamine oxidase inhibitors, like amphetamines. Anyone know how an amphetamine works? We'll mention this when we talk about ADHD towards the end of the section here. So amphetamines are basically working. They will actually also block reuptake of things like norepinephrine, dopamine. They also cause a little bit of increased release from the synapses as well. That's where you get that kind of that increased stimulant effect, where you have your much more attentive and you're much more alert, and you have your blood pressure up and your heart rate up. This can be pretty significant interaction with the monoamine oxidase inhibitors, and you also are not metabolizing those neurotransmitters anymore. So you can have very significant increases in heart rate, blood pressure, stroke. You can have arrhythmias, all kinds of bad issues. Same thing with like a lot of appetite suppressants, which are typically stimulants, cocaine, certain asthma medications specifically, like your beta-2 agonists. So again, all of these can have pretty much the same interaction here. So again, keep that in mind. Be very careful anytime you're mixing stimulants along with the monoamine oxidase inhibitor or other antidepressants, because again, that will also raise your levels of serotonin, which can lead us to serotonin syndrome, as we'll talk about later. So we don't like those drugs. Those are bad, but at least be aware of them. You may see them used occasionally, especially for early treatment-resistant depression. But you will see TCAs used much more commonly. Now, do we use TCAs for depression all the time? Not typically. What do we use them for? Not seizures necessarily. These actually cause seizures. So neuropathic pain is going to be a big one, right? So think about diabetic neuropathies, fibromyalgia. Potentially for migraine prevention. Yep, that's another one. The other thing would be for sleep. For a long time, especially in Florida, because we're kind of backwards here. I don't know if you've seen any of our typical residents, but it takes us a while to get on the ball for a lot of things. So again, mid-level providers, nurse practitioners, PAs, could not write for controlled substances for a long time, and then other providers also do not want to write for controlled substances for sleep. We'll talk about some of the sleep medications, but they tend to be controlled substances. So you could use really sedating sort of medications, and this is where you'll see TCAs being used occasionally as a non-controlled substance that can help patients with insomnia. Again, not a great drug for that. We'll talk about sleep later on, but like to avoid these whenever possible. It was, again, one reason why you might see someone using this. So if you ever see like amitriptyline, QHS, usually PRN sleep is where you're going to see the indication for that one. Another indication, so we mentioned that TCAs have anticholinergic activity. So what do you think that does to the bladder and urine management? Did you see incontinence, or should you see urinary retention? Retention, right? Because they're anticholinergic. So imagine who's asleep and might have issues holding their urine. Small children, right? So this can actually be used for bedwetting occasionally. So if you ever see like a imipramine used for a younger child at bedtime, it actually can help them retain more urine throughout the night and hopefully not wet the bed. So if you ever see that, was that the term enuresis, I believe? Nocturnal enuresis or something like that. Yeah, so that you may see being used for that occasionally. But anyway, you're going to find that these have a lot worse side effect profile compared to the SSRIs. So again, not used typically for depression, because the SSRIs are going to be a lot better from that standpoint. And again, back in the day, like this is all we had for, we had monoamine oxidase inhibitors, which we didn't like, and then we had the TCAs, which were better, but were still pretty dangerous, especially in overdose. And as I mentioned, that early phase when you're kind of treating this depression is where you kind of are at increased risk for suicidality. And so, we would back in the day, my attendings when I was in fellowship, they would talk about they'd have 4 beds in the ER set up at all times for these TCA overdoses that would be coming in. Basically, they'd all be on ventilators and on pressor support and all these things, because these drugs are super, super dangerous. And we always talk about our sphincter tone in tox and how tight your sphincter tone should be when you hear different overdoses come in. So like in SSRI, your sphincter tone's like maybe a 3 or a 4, not too high. TCA is like an 11. You're just like really, ooh, okay, better be careful with this one, right? Anyway, so some of the common ones you're going to see available here are going to include things like your amoxapine. Amitriptyline is probably the most common one you're going to run into. You also see things like dicipramine, doxepin, imipramine, nortriptylines. All these are still available out there. Again, neuropathic pain, sleep, sometimes bedwetting in a pediatric case. You'll see these, again, rarely for depression unless people have failed several other therapies, and this may be like a third or fourth line sort of agent for them, right? So I mentioned the adverse anticholinergic effects. So remember that mnemonic here, we have like they're mad as a hatter. Also not good for older patients because you can't tell, are they having cognitive decline or is it just a medication you started for them? You guys are going to be covering this a lot in geriatrics with Professor Lack. I know she was going over those lectures. You guys ever heard of the Beers list? What is the Beers list? So what you get at the bar and it says, okay, here's all the stuff we have in this game. Someone's asked me about the beer list, and I was like, it's water, yeast, hops, wheat. But so yeah, so a list of medications you should not give to elderly patients, and a lot of times it goes back to either fall risk or cognitive impairment. You're going to find that TCAs are definitely on there because of their risk for causing some of those mental status changes in the elderly. But you can also see mydriasis and impaired accommodations. They may have some vision issues. They get very hot and they get flushed. And again, even small overdoses, small changes in dose, you accidentally take 2, can lead to some of these anticholinergic effects that are much more pronounced than you expect at a therapeutic dose. Tachycardia is another big one. And from a cardiac standpoint, you also see these cardiac conduction delays, and mainly it's due to sodium channel blockade. So it's actually one of the things we look for when you're dealing with an overdose patient for a TCA, which is actually kind of cool. I don't know if you guys will find this cool at all, but I find it cool. But basically, say you're looking at normal EKG, your P wave, and you have your QRS, and then you have your T wave. Basically, what you end up seeing with a TCA is you'd actually have sodium channel blockade that actually will extend out this QRS interval, and this is a really bad interpretation, but basically, you extend out the QRS interval, and don't laugh at me too hard, I'm just a pharmacist, okay? But this is one of the things we can look at as a QRS interval, and as it gets wider, it gives us an idea of how at risk they are. I'm going to just delete that out of the video so you guys can't. That does look pretty bad. It's my stroke assessment or something, I don't know. But anyway, so you see QRS widening, and that can give you an idea of just how much a drug effect is on the heart, how at risk they are for developing seizures, how at risk they are for developing cardiac arrhythmias, and that gives us a sign if we need to initiate antidotes and things like that. So again, this is where we use EKGs as more of a diagnostic for drug effect, actually, which is kind of a different thing than you normally think of. Anywho, but also you see the alpha blockade, so you can see hypotension related to that. It actually antagonizes GABA, so if you antagonize GABA, what do you think could happen? Seizures, yeah, because GABA is our main inhibitory neurotransmitter. So if I take away that effect, you can see seizures develop from that. So again, not good stuff with these drugs and why they're so dangerous potentially. I mentioned the alpha receptor blockade, sexual dysfunction you're going to see with this, weight gain you're going to see with these drugs, and then due to some antihistamine effects along with the anticholinergic, you're going to see some sedation. Why it's good for sleep, usually lower dose than you would see used for depression. Just a little bit's enough to usually knock a lot of people out, and they'll be good for the night essentially. But again, a caveat with a lot of sleep medications, they tend to be habit forming, and a lot of people have a hard time coming off of these medications if they're using them all the time. So be really careful when you're giving out sleep medications, because rebound insomnia is a big deal for a lot of these patients. Okay, so next up we have our SSRIs, and so these are going to be your kind of gold standard, go-to, bread and butter sort of antidepressant medications. Again, very specific in their mechanism, only inhibiting reuptake of serotonin, only increasing those synaptic concentrations. They don't affect really alpha receptors or muscarinic receptors or anything like that. They're really pure in their activity here. And these are going to be first line due to the fact that they're much safer in overdose. As I mentioned, 10-fold overdose of a TCA, that could be fatal overdose. 10-fold overdose of an SSRI, not a big deal. We can handle that. We can treat through that with good supportive care. And they're generally more tolerable from a side effect standpoint. So that's good for most patients. So the ones we have here, so we have citalopram or Celexa. We have escitalopram or Lexapro. What do you think the relationship is here? Yeah, so which one's the enantiomer? The escitalopram is going to be in the enantiomer there. And again, this is something we have to do conversions of sometimes when patients come into the hospital and they're on Lexapro and we only have Celexa on formulary. We will convert them over. We'll actually just double up the dose and convert them over to that Celexa. Because remember, half of a Celexa dose is basically going to be escitalopram, right? So again, that's one of the things you may do occasionally. We have fluoxetine or Prozac, fluvoxamine, paroxetine, and then sertraline. So these are the most common SSRIs you're going to run into out there, right? So again, the nice thing here, limited side effects and much better tolerated because they really lack a lot of those kind of nasty side effects related to the kind of dirty mechanism you see with the TCAs of affecting, cholinergic receptors and alpha receptors and all of that. Less weight gain typically. Some people still have some weight gain. Some people actually have some weight loss. It just depends on how the patient responds to it. But most commonly, you're going to see some GI upset. You'll still see some sexual disturbances with this. This is somewhat common and a common reason for people to switch off of them. And then some headache and insomnia associated with that. So some people will have some sleep disturbances, right? So again, think about, like, if I have a patient who has to have a job and has to go to work or go to school or something like that, giving a TCA for depression might help fix their depressive symptoms, but they're in a groggy state because of the anticholinergic activities, may not be the best for them. This kind of alleviates a lot of that. And if anything, it might be a little bit too awake, especially like at nighttime. And so again, some insomnia management may be necessary there. So one of the things to be careful of with SSRIs is that you do want to worry about withdrawal symptoms. So again, your brain adapts to having that extra serotonin around. Again, that's those kind of neuroadaptive effects that lead to the alleviation of depressive symptoms. But you need to make sure that you're withdrawing these patients off of that. Otherwise, they can have a lot of rebound anxiety. They can have rebound insomnia, they get very, very cranky. And so they just really don't feel good. So you need to taper it down. And so one of the things you worry about, and we already mentioned, what's kind of the issue with patients taking these medications that have depression? How's their compliance? May not be great, right? So that's one of those things where they may be depressed enough where they're just like, what's the point? I'm not even going to take it, right? So compliance is an issue. So in those cases, you might want to use something that has a longer half-life, right? Things that have longer half-lives are going to have a longer tail on them as far as the levels go. So instead of having a drug, I'm scared to actually draw anything now because some guys are going to judge me, but something with a relatively short half-life, it'll have a peak and then it'll kind of die down. So if I didn't take another dose, I could have these withdrawal symptoms that would develop here. As on the other hand, though, if I were to take something that has a longer half-life, it may not peak as high, but then it would kind of go down, have a nice, more kind of gentle plateau. And so based on that, you would see that they would have less severe withdrawal symptoms. Maybe they miss a day or two, but then they get back on their regular dose and they'd be okay. So again, looking at the kinetics can be important here. Also, some of these antidepressants are going to have, these SSRIs are going to have active metabolites. What does that mean? So some of them have metabolic byproducts, so they go through the liver, get metabolized, and some of those byproducts actually have antidepressant activities as well. These also will block reuptake of serotonin. That also will extend out the duration of action, which is why things like fluoxetine or Prozac tends to have the longer half-life, the longer duration of action, and which is why it's going to be better if you have a patient you are worried about not sticking with the regimen and kind of coming off of it kind of unpredictably, I should say. So be careful with that. Make sure that you're tapering off of things. And if you're worried about compliance, a longer-acting drug is going to be a little bit better for these patients. And I mentioned even with moms who are on antidepressants throughout birth, we mentioned that even the infants can actually have withdrawal symptoms from having that exposure to SSRIs the whole pregnancy, and then when they come out, they're kind of cut off essentially, and they can have some of these withdrawal symptoms as well. So again, anyone can be affected by this potentially. The other kind of unique thing to note here, more specifically as far as side effects go, is that you want to be careful with QT prolongation with citalopram and escitalopram. It's kind of a unique fact with these. Again, if you had an overdose, this would be one thing we definitely want to check an EKG for, to make sure you didn't have QT prolongation too long, and then that could be a risk for what? Yeah, torsades would be the thing we'd be worried about in that situation. Okay, so I mentioned the black box warning for these being increased suicidality. A lot of the studies were done showed this, especially in children and adolescents, but certainly this can apply to young adults and other patients as well. So be careful with that. The reason for that is not really known, but some possible mechanism we think is, again, as I mentioned, that initial energy spike they get kind of early on. Some people will call it akathisia. Have you guys heard this term before? What is that? Kind of restlessness. Restlessness seems like a nice term for it. You ever seen anyone with akathisia before? It almost seems like they're trying to crawl out of their own skin. Like they just can't sit still. Like it feels like they have not like bugs on them necessarily, but they just can't sit down. They can't stop moving. They just want to they don't feel very comfortable in their own skin is the best way to describe it. And so sometimes that increased energy can manifest itself as them acting on some of these thoughts of self-harm. I'll never forget, I had my wisdom teeth taken out when I was a young lad. I don't know exactly what I received. I remember propofol because I remember a bottle of white stuff that was hanging up. We'll talk about that in the surgery section, but they must have given me some Versed or something. And that's another drug that could potentially cause some akathisia. And I remember the lady, I don't know if she's a nurse or a dental hygienist or whoever, was trying to help me up out of the seat into the recovery room. And I was obviously unable to walk on my own. My legs were way too wobbly. She's basically supporting my whole weight. And I wanted to start swinging at her because I was just like, stop touching me, get off of me. you know, she's like, calm down, buddy. Like, you just need to go sit down in this room. She's like, you know, and it was just the weirdest feeling. I just did not want to be touched by anyone at that point. And, you know, it kind of equated back to this kind of akathisia. So it's very strange. If you ever experience it, you definitely don't want to ever again. But that's one of those things that can happen with these patients. So this will be also important. We talk about antipsychotics, which we'll talk about a little bit later on. That'll come up again as well. Some of that due to the dopamine blockade we'll see with those medications. But and in some cases, this can actually lead to uncovering some manic episodes for bipolar patients, right? So maybe they're having a depressive episode. You start them off on an SSRI, and then all of a sudden you kick them over into a manic phase. We'll talk about bipolar in just a few minutes here. So looking at our SNRIs, again, these are going to be selective serotonin and norepinephrine reuptake inhibitors. Again, these are going to be targeting the serotonin and norepinephrine transporters. Fewer side effects in the TCAs, because typically they're not going to have nearly as much anticholinergic activity, not nearly as much anti-alpha activity. So from that standpoint, they tend to have a lot better side effect profile. Probably a little bit more than the SSRIs, but still pretty favorable compared to TCAs. These are another group where it is also beneficial for certain pain syndromes of a neuropathic origin, so things like fibromyalgia, peripheral neuropathies. These you may also see that used quite commonly. So you ever see duloxetine or venlafaxine, things like that get prescribed pretty commonly for those. And again, you notice here this relationship between venlafaxine and desvenlafaxine. Again, venlafaxine being the racemic mixture, venlafaxine being the chiral molecule, just kind of taken out of that. Why do they do that? You guys remember? Money's one. Wow, you guys are cynicals. So cynical. My goodness. It's probably money, but in some cases you may find that the one enantiomer may be where you get all your therapeutic effect, and the other ones maybe get some side effects from. So we'll try to take those out. But you also get a nice brand new 20-year patent when you pull that enantiomer out. So good for the coffers, I guess. So who knows? Anywho, so again, you'll see venlafaxine, desvenlafaxine, duloxetine is another very common one. I don't see really milnacipran and levomilnacipran, which again, you see that relationship there. I don't see those used too often, but you may see occasionally for some treatment-resistant depression. But these three are definitely the big ones, especially for neuropathic pains, especially for depression, right? So other adverse effects, you're probably going to see a little bit more GI upset than you would with the SSRIs, and that's just that additional norepinephrine effect you're kind of seeing with that. But you can still see some sexual dysfunction, so still is a risk with these patients. And then due to that norepinephrine effect, especially with venlafaxine, you can see some dose-related increase in blood pressure. So, you know, if you were asking on a test, like, you know, what's the best option for a patient with uncontrolled hypertension and depression, an SNRI might not be the best option for them because that norepinephrine is only going to increase their blood pressure versus an SSRI, probably going to be a lot more kind of blood pressure neutral in those cases. Kind of think about situations like that. Duloxetine, you may see a little bit more anticholinergic activities like nausea, dry mouth, constipation, but not nearly as bad as a TCA would be. Now we have a few mixed serotonergic agents. So anyone ever heard of trazodone before? Okay, so this is one you may see used occasionally. I see a lot of trazodone being used for sleep as another, again, a good non-narcotic sedating medication that you can use. You know, again, it's not a controlled substance, able to be prescribed by pretty much anyone. It has a cousin called nifazodone. These are basically going to be serotonin reuptake inhibitors as well, similar to previous antidepressants, but they also act as 5-HT2 antagonists. So again, what additional clinical benefit we get from that, not really sure. But the unique thing to note with trazodone is you can actually block alpha-1 receptors. So one of the unique things you see with this, especially like in super therapeutic dosing or overdose, you see hypotension related to that. Okay, so it's a unique thing with trazodone. Alpha-1 blockade, hypotension develops there. Nifazodone we don't use too often because there's some cases of liver failure. Someone kind of went by the wayside. And there's also vilazodone, which fits in this category. It's a newer drug. I haven't seen too much use of it, but there's another one that kind of fits in this category of a mixed serotonergic acting agent there. Of course, the other unique thing with trazodone, because it blocks alpha receptors, you see increased blood flow to certain areas of the body, which can lead to priapism. So it's kind of a unique side effect. So it's a good relationship to keep in mind. Trazodone, think priapism. I had a few overdose cases where I remember I was in the ER, and I think there's like a medical student, who's a young lady, who was doing a physical exam on this older gentleman who had overdosed on his trazodone. She's kind of doing her exam and everything, and then she kind of looked up. She's like, "He has an erection." It's like, oh, and I look over at him. I'm like, did you have that before? And he was like, kind of have when I took the drugs. Like, okay, that's the priapism associated with that. At which point, what do you need to do? I'm not going to do that. to call my urology buddies and see if they can come by and check it out, right? Yeah, so a lot of times as soon as the drug kind of gets metabolized and goes on its way, then that may resolve on its own. But yeah, there may be some cases where aspiration, maybe some intracavernosal phenylephrine, maybe another way you can deal with that. But again, think about the mechanism. You're causing that vasodilation. It makes sense that blood flow there would cause an erection. We haven't covered urology yet, but we'll talk about a lot of the erectile dysfunction meds there, and you'll see some similar mechanisms based on that. Anywho, I mentioned oftentimes prescribed for sleep, so you see that a lot. You say maybe trazodone 50 milligrams, QHS for sleep. You know, that's a common one you'll see. Okay, then there's bupropion. You guys remember we talked about bupropion before? Not for asthma necessarily, but for smoking cessation, right? So this one is a unique one because it actually blocks reuptake of norepinephrine and then dopamine as well. Dopamine is really important. We already talked about for Parkinson's, so it's important for movement. You know what else dopamine is really important for? You guys remember we talked about the dopamine squirts? I know you guys laughed at that, so I know you guys remember it. What was that in relation to? The reward pathway. Remember that reward pathway? Like when you go gambling and you pull the handle and you get a couple quarters out, you're like, yes, that was great. I'm going to do that again and again and again and again, and then you're out of money. Or you do cocaine, do a line of cocaine, and all of a sudden you feel really great, and you want to do that again and again and again. That's that dopamine pathway, that reward pathway. And so what's interesting is that bupropion is starting to be used because of its ability to modulate dopamine, especially in that reward pathway. It kind of helps to reset things a little bit. And you can see it being used for certain addictions. So I've seen it used as Zyban for smoking cessation, because again, nicotine is an addictive substance, and most of these addictive substances work through this dopamine pathway. So we can reset that a little bit. That can be useful. I'm starting to see it used in conjunction with another drug called naltrexone for weight loss reduction. Actually, is for supposed to be for overeating disorders. You can use this to help, because again, same way cocaine stimulates that dopamine pathway. A big juicy hamburger, or going to the Chinese buffet and getting that third plate you shouldn't have gotten, still triggers that same pathway there. So again, you'll see this used for other uses, but traditionally used as an antidepressant. And again, note that novel mechanism of blocking that reuptake of dopamines. That's an important feature there. The big thing to know here is the least amount of sexual dysfunction compared to the SSRI. So if you have a patient who has significant sexual dysfunctions, they're putting a strain on their relationship, they're just not able to either achieve orgasm or they have decreased libido, whatever it happens to be, this is a good agent to switch them over to. As long as they don't have any history of like seizure disorder, any kind of history of arrhythmias or anything like that, because you can see that with this drug. That is one of the risks we run into with bupropion. This is a great drug to switch them over to. So again, least sexual dysfunction you're going to see with bupropion. Some other kind of miscellaneous agents you'll run into. Here's one called mirtazapine or Remeron. This one is actually kind of interesting because it works as a alpha-2 autoreceptor antagonist. You guys remember where we've seen alpha-2 agonists before? What drugs? Yeah, and hypertension. We know which ones? Clonidine, yeah, clonidine is a big one. Right? It's a sympatholytic. It actually decreases outflow of things like serotonin, norepinephrine, and we saw some antihypertensives can actually act as, it can actually worsen someone's depression due to that same mechanism here. So if we have an antagonist of those receptors, that should lead to increased release of some of those catecholamines. And so that's one reason why it's thought to be useful for depression. Also will increase some serotonin activity in addition to that norepinephrine. Also, again, some of these different mixed activity of different serotonin receptors. If you think about like alpha receptors like alpha 1 and 2, beta, there's like 1, 2, and 3. Serotonin, again, has the widest variety of things. They probably have like 15 plus different subtypes of serotonin. So our purpose is not super important to remember in this particular instance is antagonizing 2 versus 3. Just know that it's going to have some mixed serotonergic activity. Certainly, though, when we talk about like the migraine medications, remember that's a 1-DMB agonist, right? Those are important ones to remember, especially when we get into different, like with our antiemetics a little bit later on in GI, like those would be 5-HT3 antagonists. Those are kind of important distinctions to keep in mind. Anywho, this one you can see some somnolence and weight gain. A lot of that is related back to some of this histamine blockade happening with this one, similar to some of the other kind of like first generation antihistamines we saw. And then this is another new one called vortioxetine. It's a newer agent working, again, similar to an SSRI and blocking serotonin reuptake, but also as a 5-HT agonist, a partial agonist, and antagonist of various receptor subtypes. Again, don't memorize this, just know it has mixed activity at a variety of different receptor types. Again, this is probably going to be better for patients who have failed several other drugs, because again, it's going to be newer, it's going to be on brand, it's going to be a lot more expensive, but it could be useful for more treatment-resistant type of patients there. Another kind of interesting thing here is you can have patients who are CYP2D6 poor metabolizers. So again, some people are just genetically more likely to be poor metabolizers of CYP2D6. They can accumulate the drug, sticks around for longer, runs your risk for more toxicity, especially of a serotonergic nature, which we'll cover in just a few minutes here. All right, any questions from the first half? Everyone feel their serotonin levels depleting, sucking all the serotonin out of the room? Feel it. I unfortunately get the dubious honor to watch Trolls on a regular basis, due to my daughter being one of the 3 movies she likes to watch. And so there's a period in the movie where they have utter hopelessness overtake them. They lose all their color, drains right out of them. I kind of see that every time. Like, you guys come back from break and you have to go through another hour. I'm like, oh, poor Trolls. Anywho, all right, so serotonin syndrome. What is serotonin syndrome? Too much serotonin, perfect. That's exactly what I like to hear. All right, yeah, that's basically what it is. This normally occurs. Now, does it happen like if I take an SSRI, do I get serotonin syndrome? No. If I take a lot of an SSRI, could I get serotonin syndrome? Maybe. If I take a lot of an SSRI plus an MAOI, yeah, this is a lot more likely. If I take a TCA plus an SSRI, much more likely. All right, so this is usually you're going to find is when you mix a lot of serotonergic meds. Anything like, well, I would never prescribe that. That wouldn't make sense. Why would I ever do that? Keep in mind, these things can happen inadvertently, right? So you have a patient who, comes to you. They say, "Hey, I'm depressed." You say, "I'm going to give you some fluoxetine." So they have a prescription for that. They go to another provider and say, "Oh, I can't sleep." And they say, "Okay, here's a TCA for this." And so they go to another doc and like, "Hey, I've diabetic neuropathy." Okay, let me give you some of this. So you can start to see where multiple medications, especially if they see multiple providers, can be an issue. Also, patients tend to hoard a lot of their medications, and so if they get depressed and they want to harm themselves, they may take all their stockpiles of stuff at the same time. So I've seen where they're taking medications from 2 or 3 years ago that they're not prescribed anymore, but they have some saved up and they just go and take it all at one time. So there's different reasons why they could develop serotonin syndrome. I'll talk about a few other clinical examples in a minute here, but the main thing you're seeing is there's too much serotonin activity, and the 4 main cardinal things you're going to see here is going to be an ultramental status. You're going to see hyperthermia, which can be pretty significant. You see the big rises in their temperature. Some autonomic instability. You know what I mean by that? No, it has more to do with mental status, but think about changes like in their blood pressure, heart rate. So it could be like hypertensive, hypotensive, bradycardia, tachycardia. So it'll kind of vacillate there. And then you're going to see some increased muscle tones. It's usually going to be increased clonus, especially in the lower limbs for whatever reason. That tends to be one of the things you're going to see there. And so those are the 4 big things we're looking for. And really, we have to call this a diagnosis of exclusion. When I say that, what do you think that means? Rule out all the other major stuff, right? So again, it could be like, this can look very similar to lots of other things. So if I had a patient who took a whole bunch of, say, ecstasy, they could look very similar to that. They could be very hot, they could have ultramental status, they could have hypertension, tachycardia, increased muscle tone. If they had CNS infection, they could have some of these similar features here. So you got to diagnose all the other things out. And once you say, okay, well, it's not really anything else, link it back to the meds. Okay, maybe it's serotonin syndrome. That's all we mean there. Because again, you'll find that with a lot of these conditions like this, supportive care is going to be the best thing as far as treatment goes, and we'll look at treatment in a second here. The main thing you're going to run into issues when you run into issues with this is if you have multiple serotonergic meds, as I mentioned. That includes tyramine reactions plus an MAOI, right? So we have a bunch of tyramine-containing food. So someone goes out to what is that, magical dining they have out there, and they're like, I'm going to have a glass of sherry with some of this nice aged meat and cheeses, and I just took my phenelzine, and then all of a sudden, boom, serotonin syndrome, right? That includes that could be another big interaction you're going to see. Mostly with MAOIs, but certainly if you mix other serotonergic meds, you can see this as well. So other signs and symptoms kind of go along with those cardinal signs. Again, very severe cases, you can see rhabdomyolysis due to the muscles just being so tense. They tend to overactivate and break down eventually, which can cause kidney failure and acidosis and all kinds of bad stuff. So you have to watch out for that. Seizures can happen occasionally. But typically, aggressive supportive care is the big thing here. So good hydration, cold IV fluids can be useful here. Evaporative cooling, anyone know what that is? Yeah, so you can spray them down with water and have a fan on them, and that will help too. When you evaporate that moisture, that will take a lot of heat along with it. So that's another very good way to do that. And there's actually another drug, which is a serotonin blocking agent called cyproheptadine. It's actually very similar to other first-generation antihistamines like your Benadryl and hydroxyzine. You can use this occasionally to counteract some of that serotonin effects. Don't use it super often, but good cooling, good hydration is going to usually be enough to help most of these patients out. And that helps with the rhabdo too if that's developing, because that'll help to flush the kidneys through, prevent that myoglobin from precipitating, causing renal failure. So some things you might not think about as far as I don't know if I had that slide on there or not. Anyway, so some things to consider when you're looking at drug selection. So things with longer half-lives or with active metabolites are going to stick around for longer. So fluoxetine is probably the one that has the longest duration of action related back to its half-life and an active metabolite. So if you had a patient who had compliance issues, this might be a really good one for them to be on, because if they miss a few days, it's probably going to be okay because those levels will stay high for a while, and you also have that active metabolite. Also, you may not need as long of a taper to prevent that withdrawal. So, and when I say taper, this is something that can happen over the course of several weeks. Some patients may be more susceptible to the withdrawal effects, and so it may be something where you say cut their dose in half for a week or two, then cut their dose in half again, and then maybe take it every other day, every 3 days, and then they're off. With something like fluoxetine, you may not need to go as gradual of a taper, because those levels will kind of self-taper on their own over the course of several days to weeks, right? You do have to be careful, on the other hand, if you're adding on a new medication, though, right? So if I was to stop fluoxetine today and start a new SSRI tomorrow, those fluoxetine levels are still sticking around, right? And so it's one of those things where you need to kind of gently, if you were to, say, have your levels again, don't laugh at me. If you were to have your levels come down on one drug, then you want to, as you titrate down on that, then you want to kind of gently titrate up on the next drug, right? So that way you'd have enough coverage. You don't have total loss of drug effect. They don't have a remission of their symptoms, but they also don't have that risk for more serotonergic toxicity, right? So something to consider there. Keep in mind that most of these SSRIs are going to be, or most of these antidepressants are metabolized through the liver. So patients who have hepatic impairment tend to have longer half-lives. So you need to monitor for that, because again, they could have extended half-lives. It could build up drug levels much higher than those who would have faster metabolism. So watch out for cirrhotic patients. Okay, so as far as therapeutic monitoring go, can I do antidepressant levels to see how happy they are? I'm going to dial up the level 10%, and you're going to be 10% happier, right? It doesn't happen that way, unfortunately. There's no good correlation between blood levels and actual, remission of symptoms or anything like that. So unfortunately, we have to go based off what the patient's telling us. Try to get a good history, get an idea of what kind of side effects they're experiencing, what if any improvements in symptoms or worsening symptoms they're experiencing there. And remember, educate them. It's going to take at least, give it 6 weeks before you really see full effects, before you start to try to switch over to something else, unless they're having intolerable side effects. That would be an indication you want to switch earlier if that's going to be the case, right? Okay. Some of the newer agents tend to lack some of those PK interactions we were seeing, so things like venlafaxine, duloxetine, bupropion, which is nice, but a lot of the SSRIs will have some CYP interactions. They don't actually induce or inhibit CYP themselves, but you may find that they are being influenced by other CYP inhibitors. So imagine if they're like on an anticonvulsant, it's an inducer like phenytoin that could affect some of these SSRIs. So again, I'm not going to put all these lists on here, but again, do a drug interaction check beforehand. Have you guys actually done any drug interaction checks before? How'd you do it?
I use Hippocrates.
Okay, so Hippocrates probably has an interaction checker built into it, right? So what do you do?
You just select whatever drugs that you
Mm-hmm.
that the patient is on or anything,
Mm-hmm.
and then it'll pop up a bunch of different interactions, and you can divide it out by the mechanism of the
Mm-hmm.
drug or anything like that. It's really easy.
Yeah, in a lot of cases, you can do it based on severity of interaction as well. So they'll have kind of like a ABCDX sort of nomenclature for a lot of those. The one I use most frequently, if you go to UpToDate, that's linked in with Lexicomp. Remember, Lexicomp's a very common one. That's our drug reference of choice over at Nemours. So I use that one most commonly. And that one has a little tab that says, drug interaction. You just click on that, put in the meds you want to know interactions for, and hit OK. We actually had a really close call. I don't know, did I mention the HEMONC patient I had just this last week when I was working? All right, so we had this HEMONC patient who came in, and so this is kind of a close call we made as far as drug interactions go. So basically, a HEMONC patient came in. A lot of those HEMONC patients are on study, right? So we mentioned with especially children's oncology, they tend to be on a lot of studies to try to identify what kind of the best regimen is going to be for them. And she happened to be on a drug called nilotinib. She happened to be in the ER for nausea, vomiting. I don't know if it was gastroenteritis, whatever it was, but she was there for nausea, vomiting. But she happened to be on this drug called nilotinib, which is not a drug we normally carry. It's a study drug for her. And so if you look at the EMR, normally you can put in a drug by the name, right? So I can put in acetaminophen on their med list, and if I prescribe something else or write an order for something else that interacts, it'll pop up and say, hey, these two drugs interact, right? That's kind of the nice thing about EMRs. Well, on this one, we couldn't really do it because it wasn't built out, so we had to just put cancer, miscellaneous drug, and in the comments, hey, it's nilotinib, right? So you lose all that interaction checking. That makes sense? Right, because it's not actually based on the drug, it's just a dummy entry you're putting in there. And so the doc wrote for ondansetron, which is, what do we use that for? Yeah, it's a Zofran's used as an antiemetic, and one of the things with Zofran, it can prolong QTC interval. So, when I got the order, it came through, it said, hey, Zofran, looked at the, looked at the patient, said, okay, everything looks good here. Go ahead and click verify. And then the nurse calls me up probably 10 minutes later. She says, hey, I was talking to the patient. They said, oh, I can't receive this. I can't actually take this drug. I'm like, oh, how come? It's like, oh, because she's on this, study drug. And I was like, oh, hold on a sec. So I actually went through, looked at the home med list and saw that she was actually on that. And I was like, well, I actually don't know anything about this drug because we don't use it very often. So did the interaction checker. Sure enough, comes up with a big X, like, don't mix these two together, QTC prolongation. I'm like, oh, thank goodness the patient was at least, privy to that information and was that, hey, hey, my hemonc doc told me not to like take any meds when, you're not supposed to, or, take any additional meds, without kind of checking on that first. So again, the EMR failed us because it wasn't really built to handle the kind of dummy injuries like that. And it's not something that, we don't normally check home meds for all those patients because you come in for gastroenteritis, you don't normally have drugs like that on board. So anyway, again, through no fault of anyone whatsoever, but we had a narrow miss where we could have, potentially, worst case scenario, or best case scenario, you'd have to get an extra EKG to check to see if QT was being prolonged. Or worst case scenario, what could happen? Going to torsades, right? So that would be very, very severe, that'd be, we'll consider, a sentinel event potentially, where the patient got a really significant harm from a drug interaction there. So again, one of those things to be very careful, make sure you're checking those home med lists. So again, if you go to LexiComp, you just go to drug interactions, put in your meds, run the checker, and it'll tell you exactly what to worry about. If it's like A, B, or C sort of interaction, it says, hey, just monitor for it. It's usually not a big deal. Like a D or an X, you want to be careful with that stuff, right? Anywho, all right. So again, the TCAs also are going to be ones that get metabolized pretty extensively through CYP enzymes. So you want to make sure to look up those interactions. And again, if you do see an interaction, start low. You can always give more drug if you need to. You can't necessarily take it back once it's there. So start low, titrate up gently. And then another thing to worry about is a lot of TCAs are highly protein bound, so you can see some interactions there. Because what would happen with the TCAs if I were to have another drug come and kick them off of the proteins? Yeah, more toxicity because more of that drug is available and not interact with receptors and whatnot. So that's one of the things you have to worry about, increased toxicity from that protein binding interaction, right? Okay, so any drug that can affect serotonin can actually lead to some of the serotonergic toxicity you have to watch out for. So even drugs you may not really think about. So you guys remember linezolid? Where do we use that? What's that for? MRSA? More specifically, even worse than MRSA, what? VRSA, so vancomycin-resistant Staph aureus, is a very good gram-positive killer. You could use it for vancomycin-resistant enterococcus. This one actually has MAOI activities as well. So you can actually see if you have a patient, so imagine you have someone come in for nasty VRE infection, go in the ICU for, sepsis. You have to put them on linezolid, but they're also on an antidepressant. Now I have these two drugs on board, and some of these antidepressants stick around for effects for weeks potentially. That's an interaction you have to watch out for. So now all of a sudden, patients having increased fever, more mental status changes, and the question is it sepsis? Is it because they're hypotensive? Is it the infection? Is it because of the drug interaction now? These are all things you have to keep on your differential when you're kind of looking at this stuff, right? Could be signs of serotonergic toxicity. Everyone ever heard of methylene blue? What is that? It's a dye we'll use. It can actually treat something called methemoglobinemia. Have I mentioned that before? Your patients look like a Smurf basically because it actually changes the hemoglobin. Has it so that hemoglobin carries water instead of oxygen, so you get this kind of Smurf-like appearance. We actually give them methylene blue to turn a blue patient pink. That's one thing I always remember about that. But basically, methylene blue is also preferentially taken up in the parathyroids. So we had a cool case. It was called into the actually, it wasn't a cool case. It was a very hot case because the guy got hyperthermic. But called into the poison center. The surgeon was coming to do a parathyroidectomy on this patient. They give him methylene blue, gets uptaken into the parathyroids, but no one screened for that interaction because he was also on an antidepressant. And so what ended up happening was they were in the middle of surgery. All of a sudden, temperature starts going up. Patient starts to have muscle rigidity. And they're like, what the heck's going on? Is it a surgical, is it a reaction to some of the anesthetics that the patient's under? Because anyone ever heard of malignant hyperthermia? We'll talk about that in the surgery section, but that's one thing you're concerned with, the patient getting general anesthesia, but it actually ended up being serotonin syndrome related to this. It's one of those things you always have to check, even if you're not using something as innocuous as methylene blue or just some random dye or something like that. Triptans are another big one because, again, how do triptans work? Remember what receptors they hit? There's serotonin, which ones? 5-HT1D and 1B, remember? So they're agonizing those receptors that cause that cerebral vessel constriction, right? So again, you can end up seeing increased effects here with some of these drugs, and they can end up seeing too much serotonin activity as well. So again, drugs you might not think about, think back to the mechanism that makes a little bit more sense there. In some cases, you may want to have a washout period where you could have 2 to 5 weeks for the drugs, antidepressant period to wash out, and then start them on the interacting med. Do you always have the luxury of that kind of time? If I have someone with a really rocking VRE infection going into sepsis, I don't really have that kind of time, right? The patient can be dead by then. So in a lot of cases, you'll find that we can't do that. We just have to kind of treat them through it and just kind of keep it on the front of our minds. If you start to see some of these changes, it could be related back to the serotonergic toxicity, right? So just always think about those things. Okay. As I mentioned, QT interval prolonging agents, you have to be careful. This is going to be more primarily seen with escitalopram and citalopram are the two big SSRIs you run into that you can see this. But, patients with behavioral health issues, unless it's very, very simple, very straightforward, like a depression, anxiety, if they have bipolar disorder, if they have any kind of concomitant, schizophrenia or any other these other conditions, you're going to see multiple these psych meds kind of all being added together. Many of them can have QTC prolonging activity, so you have to monitor for these sort of things. Look at them at baseline, make sure they're okay as far as kind of baseline QTC. Anyone know what a normal QTC is? Yeah, usually like 440 for guys, 450 for females. It's going to be a little bit longer in females, so that's typically normal. But you add on multiple of these meds, you start to see 500, 550, 600. That's when you start to really worry about things like torsades starting to pop up there, right? So you guys okay? Yeah. Anywho, and then also think about, some of these meds are going to be very sedating, like TCAs and whatnot. So if you're adding, and again, people who are depressed oftentimes abuse what substance? Alcohol, right? So then you're adding on having synergistic CNS depression. Benzodiazepines are also going to be pretty good sedatives. We talked about those a little bit with seizures. We'll talk about them more when we talk about anxiety a little bit later on in this section here. So again, keep all these kind of synergistic interactions in mind. Anyone ever heard of St. John's wort? Took him a while to get rid of it, but that cryotherapy really kicked his butt. And just kidding. No, this is a plant. You can see here. This is an herbal supplement that is actually okay to use. A lot of herbal supplements I'm not like head over heels in love with. Some people like a lot of herbals. That's okay. But this actually is decent for mild depression. The one thing we run into, and the reason why it works is because it's hypericin contained, is a monoamine oxidase inhibitor, right? So that's all well and good, but the thing you have to remember is like, you say you have a patient and you say, okay, you're depressed, I'm going to give you some Prozac, and the patient goes home and like, yeah, I guess this drug is going to be okay. I'm going to try something that worked for my great aunt Ethel too, so I'm going to go with GNC, I'm going to buy some St. John's wort. The problem you run into is these interactions here, so it's really important for education stakes to, one, make sure you cover all the potential herbal supplements they might be on, right? So ask about things they can get without a prescription, things they get that are not over the counter. You have to kind of ask them in specific ways to try to get the patients kind of cough up information about this if they don't think about these substances as drugs. And then make sure you're going to, they're not going to take these after you prescribe them something for their depression, because they're going to have some synergistic activity here. You can see serotonin toxicity is there, so you have to be careful with that one. The other big thing to worry about with St. John's wort is that it causes a boatload of drug interactions, because this is a CYP3A4 and a peak glycoprotein inducer, which means that substrates of either that protein or of that enzyme is going to cause levels to decrease, right? So if they're on simvastatin, it's going to cause those levels to go down, cholesterol go up. So be careful with that. And that's usually why I like to avoid this one, because of those a series of drug interactions. Again, if they're hell-bent on using something that's natural, I say go for it, but just be aware those interactions are going to pop up and kind of plan accordingly based on that, right? Okay, for elderly patients, oftentimes these patients are pretty overlooked. I know my grandparents, my grandpa was in World War II, and he was a tough as nails, kind of lived on the side of a mountain kind of guy, and he didn't have depression. Yeah, you still get depression, right, even if you're tough. So again, old elderly people, may not be forthright in talking about a lot of their mental health problems, but it's still something that gets overlooked, especially you see a lot of increased suicidality greater than 65 years. Big thing to note here before prescribing, look at their potential for pharmacokinetic interactions, look at their other medications they're on, look to see how their liver, their kidneys are doing, make sure you're not going to be prescribing them anything that's going to cause any big interactions there. Also, there are bigger risks for adverse effects, mainly due to having a lack of physical reserve compared to younger, healthier patients. So again, TCA is not good for these patients due to things like orthostatic hypotension. MAYs are not good for these patients. SSRIs are going to be pretty safe for the most part, but again, look at their organ function to make sure they're not going to have any issues from a liver standpoint in particular. Pediatrics, again, this is probably another patient population that's more prevalent than we think. Medications are not as well studied, but, kids are just little adults, right? So let's say no, that's not the case. They're very different, as you'll learn when we do our Kids Day coming up, right? I think I might have my kids roped into coming. So my younger daughter who's doing the newborn exam, I'm not too worried about, because she's kind of just like chills and does whatever. My toddler, though, I'm a little worried. So for those of you who may have to interact with her, I apologize beforehand. She may be a little cranky. But anywho, the medications are not super well studied for this patient population. I think fluoxetine is really the only one that has an approved indication for kids less than 18. However, I see other drugs used in this population very frequently. Again, you're just kind of adjusting your dose to effect anyway. So it's one of those things where it's going to be used off-label pretty frequently. But a lot of those black box warnings go back to that increased suicidality risk. And again, make sure you are informing family members and things like that. That hey, watch out for any changes in mood, look out for changes in behavior. Make sure if you notice anything, let's get it checked out first and just be on the safe side, especially in those first couple of weeks while they're on the medications to begin with. Because when people go to commit suicide, they typically do it where a lot of people are watching and they can be easily reached. Not usually. Usually they're trying to hide themselves away somewhere, or lock doors and things like that. So you want to try to catch these things earlier. Otherwise, you can find people in their rooms that have been there for hours, and again, time is tissue in a lot of these cases. So you want to treat this stuff early. For pregnant patients, we already talked about this briefly in the OB-GYN section, but again, we're seeing more and more moms who are on SSRIs throughout their pregnancy for postpartum depression and things like that. Again, in general, these are pretty safe for infants having exposure to this. It's just one of those things where some moms are not going to be very comfortable having drug exposure to their child, so just have that conversation with them. All right, so generally, you want to start with an SSRI or a newer agent. SNRI is okay to start with, but generally SSRIs are good to go with your first line. Generally, do not prefer TCAs unless there's maybe another concomitant reason to use that. So maybe they have like neuropathic pain or something, it might be a good option to go with that. But MAOI should be a last resort, right? Generally no good reason to use those unless they've kind of failed everything else. If you have treatment failure, you want to make sure you're assessing their compliance, make sure you're actually taking it like they're supposed to, and you've given it an adequate amount of time for it to see if it's going to kick in and actually work. So if it's less than, they tried it for a week and they're like, this stuff's terrible, it's not working, they need to try it for a little bit longer. Now, some patients will respond to different agents within the same class. So if they fail citalopram, they may do better with sertraline, or they may do better with paroxetine. So it's okay to kind of switch between the same class. More often than not, you may try to switch over to a different class. So you may go from an SSRI to SNRI, or maybe go to like bupropion. Those are all fine. There's no really right or wrong answer. It just depends on how your patient responds to it. Again, if they're having like sexual dysfunction, bupropion is a good option to go with in most of those cases. Just be careful. You don't want to like stop med 1 on one day and then start med 2 on the next, because again, you're going to see some bleed over those effects and more risk for toxicity. You have to titrate down on one as you're starting to titrate up on the other, and give it, say, like a week or so. It's generally kind of best practice. And then you may need additional therapy. So we'll talk a little bit about some other meds we use for bipolar disorder coming up. But this is where you're seeing a lot more. I see, like, whenever I go to my parents' house, I'm always astounded about how many drug commercials there are on, because like I don't have cable, but they do. So I always end up seeing. There was a lot of Food Network for whatever reason, but they watch. They have all these commercials that come on, and I see a lot of these newer antipsychotic agents that are now being used for more treatment-resistant depression. So a lot of like Abilify or aripiprazole starting to be used quite frequently for that. So we'll talk about those as we move along through this section here. So, any questions about depression? Yes, ma'am. So there's some differentiation there with the antipsychotics. The first generations tend to have a lot more side effects than the second generations do, or the atypicals. We'll go into more detail on that later on, but they're just starting to see that, yes, there is more risk for side effects. However, some patients may not get full benefit from just being on an SSRI by itself. So by adding on another agent, they may see some additional benefit. So, and especially if there's kind of more components to their illness than just kind of straight depression, especially if there's bigger anxiety issues, or there's any kind of like schizophrenia or different things like that, then we get some benefit from using one of these atypicals. Yeah. So again, it's probably more science, or more art than science, I should say. And if you talk to someone who does, psychology all the time, they would probably give you, a more definitive answer. Say, oh, for this type of patient, this is what I like to do. For this type of patient, I go with this instead. Something like that. I think it's a really important cartoon. I don't know if any of you guys have to deal with someone with mental health issues, but I never did throughout most of my life. And I used to think you just got to have some positive mental attitude. You just got to change your frame of mind. Everything's good to go, right? Not the case, right? So again, keep in mind that these are things that really need to be taken into account and really treated. You want to nip these things in the bud before they kind of spiral out of control. Because we see a lot of patients who do not have this well managed and see them in the ER after overdosing, and it's usually not a good scene. So anyway, moving on to bipolar disorder. I'm expecting all of you guys' moods to increase right now, get more excited, right? No, nothing. Okay. So what is bipolar disorder? They have a manic phase, they have a depressive phase, they kind of switch back and forth. Again, there's different subtypes. I'll have a list here, but I'm not going to go super specific into the different subtypes. It's more for Professor Austin to get into. Again, it can vary based on how frequently they're going to have these vacillations here, how often it's going to occur. But like many things in psychiatry, you're going to have non-pharmacologic therapy and pharmacologic. Usually, there's lots of drugs. Fortunately, a lot of the drugs we've already talked about come from the anticonvulsant section, so you're going to see a lot of kind of double duty we're doing here, which is good for study purposes for you guys. Because then, when you're done with this test, you can just dump all of it and not think about it ever again, right? Don't do that. Keep it all in here. You're gonna need it one day. Anywho, again, pathophys, who knows? There's probably lots of features or lots of factors that go into this, both environmental and genetic. Some of it's thought to maybe due to some kind of altered synaptic circuitry and different neurotransmitter changes, but we don't really know why it happens, but it does. And so we got some meds that we can use for that. You can hear the different subtypes. I'm not going to get super in depth on this because, again, the treatment doesn't really change specifically for our purposes. In general, you're going to find they're going to be on one med typically for the depressive stages. So, basically, antidepressant to kind of keep them from the kind of the lows, and then we're going to find them going to be on a mood stabilizer. We're going to help them during the manic phases. And with the manic phase, you're going to see that there are some that are more meant for kind of chronic therapy to kind of keep them chronically, to keep them from having a relapse. And there's going to be some that are going to be better for kind of acute phases of mania. Because again, how can that mania kind of manifest? Yeah, so some people like their manic phase, especially if they're pretty mild, because they're like, my house has never been cleaner, I have all this energy. They may not want treatment for that, right? In some cases. What's the kind of the extreme of that, though? Yeah, they get overtly psychotic, they get violent, they become a danger to themselves or others, have hallucinations, all kinds of bad things. So those are the patients that get them getting seen in the ER, where we have to treat that acutely. And so we're going to see some good agents to try to manage those acute manifestations. There's going to be some that are going to be better for kind of chronic maintenance of a lot of that. So just kind of keep that in mind. There's different phases of treatment they're going to have there. Okay, certainly you have to monitor or kind of rule out a lot of these other conditions that can can mimic mania, so things like infections, tumors, strokes, etc. Again, this is where we have to rule out a lot of drug ingestions and things like that. So you'd have patients who, if you didn't know any better, you think, okay, they're having a manic episode, a psychotic break, they're having something's wrong with them, but it could be related back to medications. You guys remember when we saw a lot of, say for instance, like the K2 and the spice, like the synthetic cannabinoids? You guys remember when those came out? I normally see someone who's on pot, how are they? Pretty chill. You ever seen someone get into a fight while they're on smoking marijuana? Not usually, right? Unless it was like laced with PCP or something. On the other hand, those the synthetic cannabinoids, which I'm sure none of you guys ever did, or if you saw anyone that may have done them, different story in a lot of cases. Like many people got very agitated off this. It had a much more of a stimulant sort of property to it, which is can mimic kind of these manic episodes. And the bath salts were even worse from that standpoint. This was basically kind of like meth you could go and buy at the gas station. Other than the meth you could buy from the back of the gas station, but it's another story altogether. Anywho, that's more of a Putnam County thing, I guess. But you have to think about things like alcohol intoxication, alcohol withdrawal especially can lead them to be very kind of mimic more of these kind of manic states. So again, rule out all this other stuff. And then once we're kind of set on it being, yes, this is bipolar disorder, this is mania, we have the different treatments we'll have available for it. So obviously our goals here are like to eliminate their symptoms, try to keep them at baseline better. A lot of times you'll find these patients are not able to, participate in normal kind of, higher functions of living, keeping a job, right? So even things like that can be very difficult, maintaining social relationships with the people around them, their family, things like that. So we want to try to get them as well managed as we can so they can try to maintain these things for longer and hopefully keep them in a good kind of psychosocial sort of a pocket there. And try to eliminate a lot of substance abuse because that is found quite commonly with a lot of these patients, either alcohol abuse or stimulants and things like that. So you want to make sure you're dealing with that because it's just only going to exacerbate their issues. Therapy needs to be really individualized. So some people are going to respond better to one agent versus another. That's just kind of how it is. So it's really kind of scattershot. It's difficult to determine what drug to go with first in a lot of cases, but we'll look at some of our different options here. And typically for most of them, they're going to be on these mood stabilizers for probably the long term as you can. Compliance is a big issue with these patients as well, especially when they're in these kind of manic phases. They oftentimes don't think they have an issue and they won't want to take their medications. So compliance can be a big deal. It can be very problematic for a lot of them if they're not really kind of kept in a good kind of stable sort of condition where they can be monitored and things like that. Anywho, we'll talk about medications that can be added on for those more kind of acute, kind of more aggressive, kind of dangerous sort of symptoms we'll see sometimes. Okay. Obviously, other things we can do, we'd like to have, good monitoring of their nutrition, exercise, et cetera. That can help to limit some of these kind of these acute phases. Good supportive counseling. Some of the mood charting can be useful if you can look for certain triggers and stressors that might kind of induce some of these manic episodes. But as we mentioned, we like drugs, so we're going to stick with drugs here. First one is lithium. Anyone know that you found lithium in 7-Up for a time? It's the original lithiated soda. So you drink it and you feel better, like, oh, my mood's so much better, like I feel pretty good. Lithium is pretty toxic though, so that didn't last for very long. So they took that out after a while. Does anyone know what other drug you could find in a common soda? Cocaine used to be found in Coca-Cola. So again, now it's just high fructose corn syrup trying to get you high. But back in the day, it was actual cocaine in there, but they had to take that out. So again, back in the day, it was a lot more fun from like a tox standpoint. You saw all kinds of weird stuff. Like Bayer used to give like heroin out as an actual product, if you ever can believe that. So there's all kinds of cool stuff they used to do. Which now we're worried about safety, whatever. Anywho, but this has been used for a long time. So since, obviously lithium has been here since the Earth's been here, but we've been using it as a treatment for mania since about 1949. Does anyone know what other metals we used to use to treat certain conditions? Yeah, you used to use mercury for syphilis. That was super toxic, which we don't do anymore. You guys ever heard of the term, yeah, gold's good for what? Yeah, rheumatoid conditions, good. We don't use those too often anymore. You ever heard the term born with a silver spoon in your mouth? What does that normally refer to, do you think? You think rich people, but actually refers to health, because silver actually has some antibacterial properties. And so if you said you were born with a silver spoon in your mouth, it means you were healthy. So it's back in like colonial days when they still had like silverware and actual silverware instead of what we have nowadays. So anyway, little tangents there. So again, we don't have a good idea. Anywho, we don't have a good idea for why this drug works. It's thought to maybe change some gene expression, maybe it's thought to have some neuroprotective effects. But what we do know pretty well is what the kinetics is. And so if you looked on the periodic table, you'd find lithium very close to sodium. They're kind of cousins on the periodic table. That means the body can't really tell the difference between lithium and sodium very well, meaning your kidneys can't tell the difference, meaning if you're in a state where you're holding on to sodium, you're going to hold on to lithium. If you're in a state where you're getting rid of sodium, you're going to get rid of lithium. That's very important because this is one that is very a potent neurotoxin that the levels are too high, and you have to monitor levels. This is one we do therapeutic drug monitoring for, and if you get levels too high for too long, you can see some very significant CNS effects, as we're going to see here. This is another one of those ones where if I hear, they have a chronic lithium overdose, that's another one I kind of, perk my sphincter tone up for. It's probably like a 7 or 8 on the scale of things versus, like a TCA being like 11. Anywho, so again, this is still considered first line by some for mood stabilization, but it's starting to take kind of a backseat to some of our other agents, as we'll see here, mainly due to the toxicity we're going to see with it. Efficacy is not going to be immediate, so it's going to take a few weeks for it to really kick in, but can help to prevent those manic episodes from occurring, can help to reduce suicide risk for some of those patients. And as I mentioned, it's critical to monitor their serum levels. And again, notice here that it's measured in milliequivalents per liter versus normal things like microgram per liter, microgram per ml, mainly because this is a cation, it's measured the same as sodium would be. So again, usually 0.5 to 1.2. I'll put the reference range if I'm going to ask about levels specifically on a test, if in regards to like what are you going to do with this patient, either change your dose or whatever, but I'll put what the reference range is. You don't have to memorize that number specifically, but just know this is what we're going to do at therapeutic drug monitoring for. And this is a pretty tight range here, right? We don't like to go, there's not a lot of wiggle room we have for these patients. So especially when you look at some of the drug interactions, even pretty innocuous drugs, you would think can have some wide or pretty big effects on the levels here. So one of the things you want to be careful of is if you have abrupt discontinuation. As I mentioned, compliance is a big issue. You can have remission curve symptoms. And then you can use it occasionally with other mood stabilizers. So we'll see a little bit like when you should combine medications. But this is going to increase your side effect profile, which we're going to see what that is in just a moment here. So, wide range of patients may develop side effects from this. Upwards of 93% of patients have at least some effects. And a lot of these things are going to be seen with more chronic dosing, right? So acutely, you think an acute dose, might see some GI upset. Chronically, though, especially and if you think about it, like, our small cations that have the positive charge, are they very lipophilic? Not really, right? They have a positive charge on them. They tend to be more water soluble. They have a hard time crossing the blood-brain barrier. So it's one of those things where it takes a lot of time for lithium to cross into the CNS, but once it's there, it likes to stick around for a while. This is why I worry about chronic overdosing for these patients, because once it's in the brain, it's hard to pull it off, and that means we're more likely to see a lot of toxicity related to that. So this is another really bad one if you have someone who has levels that have been high for a while, because they can have some pretty significant effects here. The main ones you're going to see acutely include a lot of GI distress and some osmotic diarrhea, because again, we're putting a salt into the GI tract there. Potentially some polydipsia and nocturia. Again, it's related back to sodium load or that kind of salt load on the kidney, which is detecting more of that kind of salt-like substance. It's going to try to get rid of that, and maybe some muscle weakness is another common thing you'll see. However, chronically though, and this can be some of the reasons why patients will discontinue use. You can see fine hand tremor in about half of patients. Again, it has to go with that kind of long-term CNS deposition that occurs there. Can sometimes be helped by using like a long-term, longer-acting formulation, so that way you don't get really as high peak levels, kind of more of a good plateau throughout the day. And sometimes beta blockers can be useful to kind of mitigate that due to some of the blocking the beta receptors on the skeletal muscle. Sometimes that can be useful. And then anyone ever heard of nephrogenic diabetes insipidus? What is this? So this is basically where the kidneys have an inability to manage any kind of salt and water retention. So basically the patient is going to have a huge amount of diuresis. They're going to be hyponatremic potentially because of that, because they're just losing a ton of water, losing a ton of salt. And so counterintuitively, you actually end up treating this with diuretics. I'm not going to talk about this here. We'll get more into that when we get into nephrology later on in the semester. However, it's something that can be induced by lithium and is a kind of a known side effect for this medication. So again, if you're giving it to your patient and say, oh yeah, all of a sudden I'm having to pee all the time, that can be a sign of this diabetes insipidus. It may require you to stop the drug and switch over to something else. So it's another thing to keep in mind there. So not nephrotoxicity, and actually lithium can actually interfere with hormone production, so you can see hypothyroidism, which could worsen which of their symptoms. They have bipolar disorder. Their depression, absolutely. So again, that's one of the things you want to watch out for there. You may need to check levels, TSH and T3 and all that. Other chronic effects, you can see some reversible cardiac effects. So sometimes some bradycardia and AV block can be there. So they have pre-existing cardiac conditions. You want to be careful with that. You can see some skin changes here. You can see some acne, puritic dermatitis, etc. Weight gain, slurred speech, and ataxia can develop. And then an overdose, as I mentioned, you can either have two flavors. One's acute, the one's kind of chronic. Acutely, not such a big issue if you can get rid of it very quickly, but the chronic ones are the ones you have to be careful of. These are patients, and we mentioned this is handled through the kidneys just like salt, so it's 100% renally eliminated. So you have to watch for these patients, because if their renal function takes a hit, you have to adjust their dose. Otherwise, levels are going to start to climb. This stuff is going to get into the CNS, and you're going to see things like the seizures start to develop. And once they start to seize, it's really not very good for that patient. So you have to be careful with that. And then this is some cases where we actually put patients on dialysis to help pull this off. I'm not going to test you on that necessarily, but just know you have to be very careful with this stuff in chronic overdoses, especially with some of the drug interactions we're going to look at in just a second here. So anything that is causing the body to hold on to more sodium is going to cause the body to hold on to more lithium. And so things like dehydration, sodium restriction, heart failure, cirrhosis, any of that can lead to drug accumulation. So those are patients, if you're starting to see acute changes in any of these, you want to go ahead and check a level to see where they're at. Other things that can do this as well, so diuretics can put your kidneys into a state where they're holding on to more salt or trying to compensate for that diuretic effect, so that could lead levels to get higher. And then NSAIDs and ACE inhibitors, based on their effects on both the afferent and the efferent arterial, if you can think back on all those we covered, those also were going to lead to decreased glomerular filtration. More of that lithium is going to be held on to. And so I've had several patients who get admitted to go to the ER and get admitted upstairs because their levels of lithium are too high. You're trying to figure out, like, they're otherwise healthy, and you're like, why are their levels so high? And the guy's like, yeah, I'm taking it like I'm supposed to. I don't know what happened. And then you go and say, well, are there any new medications you're taking? And he's like, oh yeah, well, I started working out, and all of a sudden my muscles were real sore. I started taking ibuprofen. It's like, there it is. So I started taking ibuprofen, decreased renal filtration, held on to more lithium, and boom, he's got the CNS side effects. So those are always questions you want to ask with lithium. Make sure there's no new meds they're on, and warn them before taking anything like an ACE inhibitor or an ACE NSAID or something like that can interact there, right? You get no CYP interactions to worry about, but really these are the big ones. So that renal elimination, you have to watch out for. So any change in renal function, again, you got to check a level. So lithium's good, but it's got a lot of the side effects. We don't like that from that standpoint. So instead, we use a lot of anticonvulsants, which we've already talked about several of these. So valproic acid, probably becoming one of the most commonly prescribed mood stabilizers nowadays. We know that had lots of mechanisms, working on calcium channels, helping to make GABA work a little bit better, some sodium channel blockade. good for either acute mania and for chronic therapy. So potentially, you had a patient who's having an acute manic episode, you can give them a big dose of IV valproic acid, get their levels up, and then start them on chronic oral therapy. That could be one option. And again, you can sometimes use this with other agents. However, again, side effects are going to go up. So you want to be careful with that, especially with one of the ones we're going to talk about a little bit later, another anticonvulsant we'll see in just in a minute here. But you guys are familiar with the side effects of valproic acid. The main ones are going to be what? Kind of a common side effect you see of valproic acid. CNS depression is going to be a big one, right? So again, think about, and that kind of makes sense because they're manic and they have way too much energy. Give them something that's going to kind of stabilize that mood down a little bit, kind of bring them down, chill them out a little bit. CNS depression might be a good thing because again, you're hyperpolarizing those neurons. So think back to your seizure lectures. You can see some fine hand tremor here as well, some GI distress. Those are the most common things you're going to run into. But remember, hepatotoxicity is a big thing. Remember the pancreatitis you can see with these ones. These are other organ damage you can see that are more common with valproic acid and some of the other medications. Okay. Again, you're going to monitor levels with this one, just like we saw with the antiepileptics. We're monitoring for hepatic functions. So these are all things to consider when you're monitoring for these patients or setting up follow-up visits. We also use carbamazepine. You guys remember what electrolyte you want to look at with carbamazepine? Sodium, yeah, because the SIADH you can have developed from that. So again, we'll see oxcarbazepines on this list as well. Again, that's another big one for SIADH, so you want to watch sodium for these guys. Again, purely sodium channel blockade from a mechanistic standpoint. And this, again, is not usually first line. Sometimes you use it if a patient, maybe was refractory to lithium. This could be a good one to use as a backup. Usually I see valproic acid kind of being more of a first line go-to in a lot of those cases. We talked about side effects here. You can watch for that sodium channel, the loss of sodium due to SIADH, that kind of dilutional type of effect. And remember those drug interactions. This is one that it has several inductions, especially CYP3A4, so that can interact with other anticonvulsants, your oral contraceptives, etc. So watch out for that. There's one interaction between valproic acid and carbamazepine, so in the rare occasion you mix those two together, you do have to watch out for that since it can increase levels, the free levels of either one of those drugs, so you may need to monitor or adjust the dose down somewhat. Again, oxcarbazepine is another one you could use in cousin to carbamazepine. Think of them very similarly, but fewer drug interactions and more SIADH. So those are kind of the big differences with that one. A little bit of CYP induction of CYP3A4, but not nearly as much as you would see with carbamazepine. So again, fewer drug interactions than that one. Next we have Lamictal. Remember the big side effect to watch for with Lamictal? Rash, dermatologic changes, Stevens-Johnson's, those are the big things you want to watch out for this one. This one's good because it actually has a little bit of antidepressant effect, as we'll see. So again, kind of pulling a little bit of double duty there for some of these patients, which is nice. Big thing to note with this one is remember how we saw that if you have like an inducer of metabolism, you have to do what to the lamotrigine dose? You have to raise it or lower it if you have an inducer of metabolism. You have to increase the levels. And the common thing we saw here was that valproic acid used as a mood stabilizer along with Lamictal. That's actually an inhibitor of metabolism. So in that case, you'd have to do what to the lamotrigine level? Drop it down. So you have to drop it by half essentially in order to make sure you overcome the interaction, because otherwise your lamotrigine levels are too high and all of a sudden they have rash, they have you start to have desquamation, you worry about Stevens-Johnson. It's not good. So watch out for that. I'm going to go into these quick because I know we've covered them already. So again, reference back your neuro lectures to get most of the stuff we've covered on these already. Okay, so then briefly about the antipsychotics. I'm going to finish up the bipolar section here, and then we'll finish up for the day. Anyway, so we'll talk more about these in greater detail when we get to the full antipsychotic section later on, but these are common agents we'll also use for bipolar disorder. There's two primary generations of these, and you covered these already with Professor Austin, correct? So you have your first generation agents, which are older, tend to have more side effects associated with them, and then you have the second generation, otherwise known as atypical antipsychotics. These are much more commonly used for bipolar disorder. So usually these are going to be add-on agents you can use in addition to another mood stabilizer like valproic acid or lithium. The other thing with these agents, you remember any big side effects you see with these drugs? Sedation's a big thing, right? So again, oftentimes you ever seen anyone like an acutely agitated patient get a big dose of Haldol or haloperidol, or they get Geodon. You can knock out an elephant with these drugs, okay? So this is really good if you have a patient who's like acutely agitated, who's fighting the hospital staff, things like that. These are very good drugs to knock them out and kind of get them kind of chilled out, and then you can start them on some other kind of maintenance therapy, right? So for instance, I remember I had this one guy in the ER, and this is in downtown Jacksonville, which is kind of a crazy place to begin with, right? And this guy was like taking the cake for that night. And so he was, I just remember him screaming. Again, this is, probably 30 some odd, like kind of critical care area of the ER. And this guy is like sitting there fighting. There's probably like 8 nurses there and 10 techs trying to hold this guy down. We're kind of ruled out drug ingestion. It really just seemed like he was just in this manic episode. And he was talking about, he's like, I'm an atomic bomb. I'm going to go off. When I go off, you guys aren't going to see me. And he's spitting at people and trying to punch people and just no good. And all of a sudden, all I hear is, and then I'm going to do this. And so, fortunately, they give him a big dose of Geodon. They got it intramuscularly because, again, that guy was not one we're going to get an IV on anytime soon. Big dose of IM Geodon, knocked him right out, and then they can get him kind of under control, get him strapped up and restraints and all that good stuff. So, again, these are very good agents for the acute phase, and they can also be used for more kind of chronic therapy. So, keep that in mind. Anyway, we're going to see that these have a lot of metabolic effects as we look at this section more in depth later on. So things like type 2 diabetes, weight gain, are going to be a big concern for a lot of these patients for chronic use. So we'll look at that later on. So again, more to come on that a little bit later. The other thing you might see as far as alternative agents go, benzodiazepines are very good for acute agitation, acute mania. These are not really good for necessarily for chronic maintenance, though, because again, there's a lot of tolerance that developed to benzos over time. But we'll talk more about those when we get to the anxiety section later on in this section next time. But again, this may be good for patients who cannot tolerate mood stabilizers for whatever reason. So kind of keep that in mind. There's some thought you can use calcium channel antagonists like verapamil or nimodipine, but I don't see these used too often. But I just kind of keep them here for completeness sake. It is one option if they could not tolerate a lot of these other medications. So in general, you want to start off with a mood stabilizing agent. It should be on something for their depression, and it should be on a mood stabilizing agent like lithium, carbamazepine, valproic acid, or a second generation antipsychotic. If they're still having anxiety, insomnia issues, doesn't matter, benzodiazepine can still be useful for that. It's kind of an adjunctive agent, usually on like a as needed sort of basis there. Oxcarbazepine can be an alternative potentially, and then they may need to start with 2 agents if they're having really severe kind of manic episodes. So again, you might do like a valproic acid plus lamotrigine, or a second generation antipsychotic plus valproic acid, something like that. And they're still having inadequate responses, so you can add on multiple agents. But again, when you add on more than one agent, you see more what? Side effects. You got to worry about that. So again, that's the kind of general concern. Start with one agent, see how they respond, try to maximize dose, and then if they can't tolerate the drug or it's not that effective, you can add on something else to that or switch them over to a different drug. Make sense? Okay. Any questions? I'm trying to move you guys from the boohoo pile to the woohoo pile. So I'll see you guys next week. Have a good weekend.